Good afternoon, everybody. Welcome to our monthly Illuminating series. My name is Holly, and I'm the Community Engagement Coordinator here at Lumina. This is a series that happens monthly. It's every third Tuesday of the month. We have different topics each time on life, such as healthy aging. This topic that we're on right now, advanced care planning, grief and loss, and other end-of-life experiences. And as I mentioned, today we'll be talking about advanced care planning. This is the first part of a three-part series on advanced care planning. So specifically today we'll be talking about how to start the conversation about advanced care planning with your loved ones. So for today, go ahead and use the chat box. If you have questions or comments, we will be asking some poll questions throughout, but also we'll ask some questions where you can answer in the chat. And keep in mind that we are recording today's presentation, and then we'll make that available to you afterwards via email. And so before we get started, I'm going to send you our first poll question. So take a moment to answer that, and it'll give us an idea of who is here today. Okay, should be able to see that now. And while we're answering the poll question, I just wanted to share a little bit about our two presenters today. Tamina Teray is going to be up first, and she's a professor in the Behavioral Sciences Division at Western Oregon University and a board member here at Lumina. And our next presenter will be Dr. Helen Gao, and she is our medical director of clinical innovations here at Lumina. And I have to just mention that last week, Helen was named 2022 Clinician of the Year by the American Geriatric Society, which we're all very excited about. And we're thrilled to have both Tamina and Helen here today. So as the poll is coming to a close here, and then I will pass it off to Tamina. Okay, looks like we have about 60% is interested individuals in the topic for today, and about 34% hospice staff or volunteers, and looks like we have one person coming to us from a senior living facility. Okay, close the poll there. Okay, take it away, Tamina.
All right, let me get my slides up. Hello, everybody. I'm just thrilled to be here. So excited to be back on Lumina's board. And I have taught death and dying end-of-life courses at Western for more years than I want to state to all of you, because if I tell you, and when I tell my students, they start counting how old I am. So we're not going to do that today. But it's been a few years, let's just say. And I find these topics really, really important to talk about. The death and dying class that I've taught for many years, it closes faster than any other course in behavioral sciences. And that's because people are very interested, not always comfortable, but very interested in end-of-life topics. And so I'm glad you're here today, even though there may be some uncomfortable feelings. So we'll talk about that. So I'm going to go ahead and start my slideshow, and with the help of Holly, we will be polling on a couple of these slides, and then there's a chat question after these slides. And I want to say that my background as a developmental psychologist means that I really like reciprocity. And if we can do some interaction today, that's fantastic. So if these poll questions and the chat question that comes after these next two poll questions, if we can get into some interaction, then maybe we can cover some of the material without me ever going to my slides. But if that doesn't happen, I have a few slides. So I've always got that in my back pocket as a teacher. But I'm happy to have an interactive time with you. And Holly's going to keep me on the clock too. So there's the first poll question.
Okay, it looks like almost everyone has answered.
Okay. Get that out of there. So clearly we have a biased group here. We have a biased sample, as we would say in psychology. And those of you who signed up for this talk, many of you are staff members, some of you are not. But I would say that this is really good news that the vast majority of you have filled out some kind of advanced care planning document. I will fess up and tell you that when I first started teaching death and dying, I had not done that. And my students were very surprised and they made me honest. So I think it's great. I also think it's great for those of you who have not filled out any advanced care planning documents and you are interested in doing that or maybe confused by what they are. And I know that Helen's going to do a really good job in focusing in more on those specific documents. My part of the talk is just how in the world do we open up these difficult conversations? How do we do that? So that's me, my part. Okay, so the next slide I have. Poll question about how comfortable you are discussing illness, death, dying, anything related to end of life in that way. Something I ask my students quite often. I see where we're going here.
Looks like everyone that can do the poll has done it.
Okay, so it would be nice if we could correlate the last poll question with this poll question. So the last poll question, have you filled out advanced care planning documents? And then this poll question is how comfortable? Well, if the same people who filled out advanced care planning documents were really comfortable, that would make sense. But it may be that these are two different groups too. I'm comfortable talking about this stuff, but I haven't gotten to the point where I've actually filled these out. And I love that, 29% of folks are somewhat comfortable. That makes good sense. Not comfortable at all, we would see more people in the general population that would fit into that category. But because this is a biased sample we got here, I may be speaking to the choir a little bit today, but that's okay. And the reason it's okay is because I expect you then to be mini death educators after today and go out and do the ripple effect where we're in the pond and we're throwing that little rock and we're getting some ripples. So I can only speak to X number of people at a time, but then you speak to other people. And I think that's a really good thing. By the way, I'm the kind of person that it's kind of embarrassing that at even holiday dinners, I will bring this stuff up and I will even have advanced care planning documents with me, not polls, because I can't fill that out, but advanced directives. And so it's a running joke that you don't want to invite me over for any holidays. Okay, let's go to the next one. I move everybody over here. I just really like cartoons. And I think this is very true that difficult conversations don't go away. They just get harder. We can try to put them aside, but they will come up. And so it's probably best that we do face these conversations so that we can go on and enjoy life more. So I thought that was kind of a fun one. So here's a chat question. Maybe we can interact a little more now versus a poll question. If you think, this is kind of loaded question. So I'm saying, why is it important? That's loaded, but that's okay. Why is it important to share our wishes with with friends and family members regarding our end of life, needs and concerns and what we want. Why do we need to do that? If you think we need to do that, why is it important to discuss our death process, our post-death wishes? What do you think? So if you could put a few of your wonderful thoughts in the chat, then Holly will share some of those with us, and maybe we can have some interaction around that. And if you don't think it's important, I really want you to put that in there too.
It's quiet so far, Tamina, but
Nope, we
here
gotta
it
have some
comes.
chat. That's, I never give my students enough time. So I'm gonna give you a little bit more time. I ask them a question and they don't answer, I go right on. But we need to give more time. So I think I think Angela's writing something.
We've got some coming through.
Yeah.
Mm-hmm. Can you see, or do you want me to read them?
No, I cannot see them.
Okay. Okay, I'm just gonna go down the line. We might not have the capacity to share those wishes at end of life. It alleviates some of that decision-making for your loved ones.
Can we stop just for those two? Because I think just mentioned. So this is the first chat question was great. We may not have the capacity. So this makes the point regarding why advanced care planning is so important. If we don't have the capacity, that's exactly why advanced directives and PULSE are so important. They speak when we can't. And so that's a great point. And I'm sorry, the second one?
I'll read the next two. They kind of go together.
Great.
It alleviates some of that decision-making for your loved ones during that time. And the next one is, I don't want to burden my family with having to project, assume, or guess what my desires at the end of life would be.
So in the next number of slides, if we get to them, I talk about how stressful end of life is for everybody in terms of a family member who's dying, a friend who's dying, and it's already difficult. And if we don't know what their wishes are, then it becomes even more chaotic and more difficult. So we can mitigate, we can reduce that stress by knowing what they wish, by knowing what they want. And I think this is very, very important. So that is just spot on. We can make things easier. And so that's great motivation, isn't it?
Mm-hmm.
Yeah.
Okay, I'll keep reading. Because it's a little late to discuss after I'm dead. We just talked about that. And if you don't talk about it, you can't plan. And if you don't plan, you will not have the death that you want.
Yeah. So often I hear people say, it doesn't matter. For my students, for instance, let my parents, or for non-students, let, my husband, wife, partner, let whomever decide for me. That's a burden on them, like that last question said. That's not so easy for them. So with information, I think that's really true, that it does make it easier. And then after we die, it's a little too late to be talking about those things. So it's really important that we make those wishes known beforehand. And if you look at the research, the vast majority of people, when they are queried, they know what they want and don't want. It's going that next step and filling out the appropriate advanced care planning documents in order to know, legally, if you will, and make that a lot easier for family members to do that. So yeah, good questions. Statements.
Okay, some more. During the grief stage, it's too difficult to have to make those decisions. I want to make sure that I'm able to die at home and not in the hospital. And this kind of goes with that. So we can have the kind of death that is consistent with our priorities and values, and to give our loved ones confidence in making decisions.
Oh, I love that. Yeah. So if you give your loved ones enough information, they can have the confidence, the information. I want to go back to grief too. I spent a lot of time in my classes talking about grief. And when we are grieving, it's a whole body response. And cognitively, we're very affected often. And so our prefrontal cortex, that is the manager that makes all these great decisions for us, is kaput. That's not a sophisticated psychological, statement there, but it is. It's really diminished, if you will. And so it's very hard to make those decisions that are important to us, be an end of life or anything else, when we are grieving. And so it's much better to do this prior to having any kind of grief process going on. And those questions in the last set had something about, in a way, having some control, some autonomy over my death process. And I think most people do want some autonomy over the way they die. And, advanced directives, for instance, don't have this in them, but we can put a little addendum and, who do you want to come visit you in your home or in the hospital? And that was part of the question, where do you want to die? Some of us might have family members that we would really prefer not to see on our deathbed. Well, who's going to protect us if we don't let that be known? I'm not saying that happens in families, but yeah, I think it does. I have one of those in my family, and I would like, that to be known, that there are people I want to see and people I don't want to see. Even if I can't speak, the presence in one's room at home or in the hospital can make a big difference. Great questions and comments. Anything else, Holly?
Yes, we have some more talk about, not having your family members have to deal with that during their grieving. And then also, so we know the preferences of our loved ones, and that it opens the door to them asking the question for themselves. And so you can get, you're not just sharing your wishes, but they're sharing back as well.
Yeah, and so I would, definitely I'm going to get to this last slide that I have. It's a national group that helps us have these conversations, and having a conversation with somebody about our wishes almost always opens up other conversations. So not just what we want, but then they talk about what they want, and then other people that they talk to talk about what they want. So it really is a fascinating door that gets opened. And so often people want to talk about these things, but no one has given them the opportunity. You are a strange group. Like I said, you're a biased group. In our society, we are not taught to open up and talk about death and dying. It's a taboo. It really, really is. There are a few cultures within our society that is not the case. But overall, in the United States, it's just not something that we're comfortable with. So when my students say, well, I just don't understand why I'm not comfortable talking about this stuff, I tell them, well, why would you? Why would you be? When did you learn how to talk about death and dying? I imagine as children, if they mentioned that in certain households, that was shut off real quick. So I would like to go to my slides, I think, Holly, unless there's something else that you think.
Yeah, there was just one comment that I really like.
Good.
It says, I live more fully knowing that I'm organized for end of life.
Isn't that interesting? And the research points that out. Absolutely. Findings suggest that anybody who has filled out advanced care planning documents, it's a relief. And then they feel less what they call death anxiety. They feel more prepared. They can live more fully. So whoever said that is spot on, and they knew the research, even though I didn't have that study in front of me. Awesome. Well, if something comes up, let me know. And at any point, you can put something in the chat over the next 10 minutes that I have, and we'll go from there. The conversation project, and Holly's going to send a PDF of my slides and Helen's slides, so you'll have this, so don't worry about it. This is a fantastic group that has put together documents to help you have these difficult conversations. And I highly suggest you go to the conversation project. And I had taken the next couple slides and made them my own using information from the conversation project. But yes, they can be difficult, these conversations. And we just said a lot of this, so I'm not surprised with this group. We are not prepared by our society to have end of life conversations. So oftentimes we need to figure out ways to do that that are not so challenging. The textbook that I use in my class by Core and Doka, I love this. Charles Core says, for all topics related to death and dying, we need to become comfortable with our discomfort. So if you're waiting to be comfortable without discomfort, good luck with that. For many, I mean, not all of you, but many people in society, if they're waiting for that, it is not going to happen. So it's sitting with, if you will, our discomfort, but being willing to move forward and have these conversations. It's worth it. So what are the benefits? You've all told me. So, you are that second part of the slide. People don't have to have the chaos. Family members and friends know your wishes. All of those can happen. These medical interventions that you want or don't want. See, this is what's beautiful about the advanced directive and the pulse. All kinds of options for what you do or do not want in terms of end-of-life interventions. Medical interventions when you can't speak for yourself. You can speak for yourself, you don't need those because you can tell people, this is what I want, this is what I don't want. And then end of life, I gotta move you all over a little bit here. End of life is already stressful and you already told me that. So why would we not want to reduce that stress? Absolutely. Okay, so let me go here. How do you do it? You got to find the right time. This is true for any difficult conversations. You need to bring up something stressful in your life with your spouse, your children. You got to find the right time. And in terms of end of life conversations, we have to have these conversations, if we can, when we're healthy. When we're healthy and we're clear-minded and we don't have diminished capacity mentally, so that we really have the ability to fill out these documents and have these thorough conversations. Who should we have these conversations with? The bias in the field of death and dying, it's called thanatology, is anyone 18 and older, because that's what these documents call for, especially advanced directive, anyone 18 and older, anyone in that age group can fill out an advanced directive. A lot of times people feel like they're too young or too old. Helen will talk about the difference between advanced directive and a pulse, so I'm not going to go there, but right now I'm talking about an advanced directive for sure. All right. So what else then in terms of starting this conversation? We have to create the right environment. We have to plan ahead. Asking permission is always a good idea. I'd like to talk to you about how you wish to be cared for if you get too sick to decide for yourself, just one example. And then maybe select an appropriate setting. This is true for any difficult conversation, isn't it? You want one without distractions. Turn your phones off, get away from any distractions so you can have a quiet and comfortable and private place to have these talks. That really helps. Okay, so what do we need to do then in these conversations? We can use some conversation starters, sharing our own wishes, telling someone, and this came up in the chat, about what we want. And by doing that, you're opening the door, that special door that allows for two-way conversations to take place. If you're brave enough to open up that door, wow, they might think I can do this. Use a situation that you saw occur. An example, when grandma died, you mentioned you did not know what her wishes were. And that made things, a lot more difficult for you. So I think bringing up tangible, documented examples can be very helpful. Okay. What to say? If you were diagnosed, just a couple samples, if you were diagnosed with a life-limiting, that's kind of the old language is terminal, life-limiting is a newer language, illness. What types of treatment would you prefer and not prefer? One nice thing about the advanced directive, it's now a pamphlet. So it has a lot of different examples instead of just, going through that last part. Where would you prefer to die? This came up in the chat, a hospital or at home. My goodness, if we don't know that about our loved ones or about ourselves, that's really important information to share with people that we care for. I love this too, and I think about this a lot. What can I or others do to best support you in your choices? Man, that's really important information. And lastly, I just want to share with you a project that I have my students do in my death and dying class. And I'll tell you, this is something you can use to open that door wide. There's an organization called Death Over Dinner, and you just deathoverdinner.org. And if you so choose, you can tailor make, and then it spits out questions for you, which is really awesome. Tailor make a discussion guide. They have podcasts, videos, and articles, and you can choose which ones you want. You can choose the audience, meaning, am I talking to a loved one? Am I talking to a coworker, a friend, a roommate for my students? And then with this discussion guide, you can have these starters. And this is just really an easy way to help get through the muddle and the difficulty of these conversations. So just some of the topics would be your thoughts and concerns about your own mortality or the mortality of someone you love. Wishes during end of life, we talked about that. Medical interventions, we talked about that. And something we don't talk about enough is post-death, right? What do we want post-death? Do we want a ceremony of life? Do we want a funeral? Do we want to be buried or cremated? So these are really great ways to get started, both the Death Over Dinner and the Conversation Project. So I think both of those are just really fantastic. So just to end, look at me, I'm doing really well. Talking about end of life wishes is potentially very challenging. Now you guys in this audience, not so much, but I'm sure as you've talked to other folks, you have found that they can be, very reticent to talk about death and dying, to talk about grief, to get these advanced care planning documents filled out. So, if we do, we may lessen the stress and chaos at the end of life for ourselves and others. That's pretty good reason. Okay, let me stop my share. And so I guess we got a couple minutes. If there's a chat question that popped up.
I haven't had any questions yet.
Okay. Well, as we're just sitting here for a minute, there goes Naomi's got something in the chat. Hi, Naomi. I can't read that.
She is mentioning a death cafe is another great group to talk about death and dying.
Yes, thank you for mentioning that. Sorry about that, Naomi. And Naomi does a great job providing a container for the death cafes. And that's something that has popped up in many, many cultures, many societies over the last number of years. And it's just wonderful. Pre-COVID, people were meeting in person. During COVID, Zoom, hopefully that'll go back to meeting in person again. So it's a great way to share how one is just walking through life and carrying questions about death and grief. Yeah, and end of life planning. So we do, whether we want to or not, like that little cartoon said, it's not going away. Just like when we grieve, we can't not grieve. We will grieve, whether we decide to push that back for a while. It's on our shoulder and it will show up. But I think it's exciting, actually. I think preparing for the end of our lives and post-death is very, very exciting and empowering. Let's see something else.
We had a comment in the chat. I think it's hard to think of oneself as qualified to start these conversations with loved ones.
Oh, isn't that great? You know what? We're all in the same boat. I don't care if you teach death and dying, if you work for hospice, we are all in the same boat in terms of just starting the conversation with somebody. You don't have to have special skills. When I teach my death and dying class, we talk about how to support someone who's grieving. I tell students there's one thing you have to do. Does anybody want to guess what that is? What's the most important thing you can do for somebody who's grieving? Anybody guess? Megan, be present. Perfect. Show up and be there. Okay, this is the same thing, folks. You're showing up, right? You're opening the door. And after that, just starting that conversation. It is amazing where these conversations can go. You do not have to have expertise, but I do suggest between the death cafes, death over dinner, right? And the conversation starter that I talked about, the conversation project, look at that stuff first if you want to feel a little bit more confident in it. But I can tell you, you don't have to be an expert. There's no such thing. Okay. Great. Well, I want to stay on time so Helen can have her time. So, thank you.
Thanks, Tamina.
Thanks, Mina. I'm going to add one more resource, which I've shared before, along with the conversation project. Prepare for Your Care is another one. If you just Google Prepare for Your Care, it's very similar to the conversation project, and it also has materials in Spanish, and I believe they're translating it into other languages as well. So that's another resource. I'll go ahead and share my screen.
And we'll share all these, like Tamina said, you all get the slides, but we'll make these hot links available to you via email, so it's easy for you to find.
All right, can everyone see the screen? Okay.
Yep.
So I'm going to be tag teaming and following up more on, what does it mean when we talk about end of life choices and healthcare decisions? Often the focus comes down to very specific types of interventions, even though really the conversation can be very broad about all kinds of preferences for care. But I'm going to talk a little bit from the medical side of things so that people can understand, like, what does end of life, acute decision making come down to. So to really follow up on what Tamina said, the objectives for today is first to just acknowledge that death is universal, and then recognize that many experiences influence a person's understanding of death and dying. And then finally, I'm going to describe in detail, what happens with the two interventions of CPR, cardiopulmonary resuscitation, and mechanical ventilation. And we're going to start with the first poll, which is, have you personally experienced or witnessed a loved one, or for those of you who work in this field, dying? So it looks like the majority of folks in the audience have experienced a loved one dying. So great. And a small number who haven't. Oops. Can I advance, Holly? There we go. And then next question, if you had to describe, for those of you who have experienced the death of a loved one, if you had to describe your experience of death in a few words, what words would you choose? And go ahead and enter them in the chat.
We have some words coming in on the chat. Not pleasant, peaceful, chaos, intimate, serene, graceful, sacred, privileged to be a part of, unreal, profound, grateful, shocking, stressful, powerful, unexpected.
Okay, great. Thank you. Not surprisingly, the full gamut of life experience, positive and negative. So what I want to talk about first is, we know that death is a universal human experience. These are some diagrams that try to give kind of a picture graphic for the types of sort of life experience and decline that a person can experience leading up to death. So there's sort of four main modes that we describe in healthcare. One is, I think, what some people are afraid of, but in some ways, you might say it's a blessing, to have sudden death. You're going along with life, you're enjoying life, you have no idea you have something potentially catastrophic coming along, and boom, you die. Ideally, it would happen in your sleep. Maybe it doesn't. Maybe it happens during your waking hours. And whether or not it's traumatic or not, I think really depends on whether it happens to someone in sort of what's considered younger ages versus older ages. Then there might be this one in the top right, which is terminal illness, where you're going along with life, life is going along well, and then you get a very major diagnosis, such as cancer. And then from the time of that diagnosis, you may have a decline in your health that is fairly rapid until death. On the bottom left is what we see very commonly amongst the many individuals in our community who have varying levels of what we call organ failure. So this could be congestive heart failure. This could be chronic lung disease. This could be dementia, where you're functioning and then you have a dip because you got sick or you had a fall, and then you kind of bounce back up, but not quite back to where you were before. And then something else happens, you dip down again, and you never quite make it up in this perpetual kind of stepwise downturn in your health, and slowly your function declines over time until you die. And then the last pictorial on the bottom right is what we call frailty, where you've reached a place of fairly low level functioning. You're dependent in a lot of help, and you're sort of, some people call it failure to thrive, or the dwindles. You're just slowly declining over time. Nothing major happens, but you're getting progressively weaker, progressively more dependent, until you don't have the strength to continue and your body dies. So you'll notice with all of these, there's a very common end to all of them, which is death, the universal human experience. And despite a lot of advancements in medicine and in science, I hate to break it to you, as you all know, there is no cure yet for death. And I, for one, hope that we don't have a cure for death, because I think it gives life far more meaning when we know that we have a finite time on this earth. So to follow up on that idea that there are different ways that a person can experience their life up until their death, I think it's important to recognize that another very common experience, not always universal, but the majority of individuals as we get older or with increasing illness are going to experience some level of disability in our life. So by the time you reach the age of 80s or over, a good almost 70% of individuals are going to have some level of household activity disability. And about 2 in 5 individuals over the age of 80 are going to have mobility difficulty, walking, getting up and down from a chair, trying to go up a step. And oftentimes mobility disability translates into difficulty with some of the personal care things that a person often is strongly attached to from a standpoint of independence, being able to toilet oneself, being able to take a bath or shower oneself to get dressed. So recognizing that, we have the ability in healthcare to extend longevity in many awesome ways, I think it's important to recognize that our ability to prevent disability is not as good in terms of medical advancements. So the next poll question is, if you have not experienced or witnessed death firsthand, or if you have, where do you tend to get your information about death and dying? Okay, I think we'll stop it there. About half of folks replied. And I think, as Tamina noted, we have a fairly death savvy audience today. A lot of individuals who get information from some of the community facing events, as Tamina discussed, like Death Cafe or presentations such as what we do here at Lumina. Organizations like the Alzheimer's Association, disease-specific organizations, personal relations with friends and family sharing stories about death and dying, and a small number from TV shows and movies. So you guys break the mold. Okay. So one thing that's very clear, at least in terms of public perception about death and dying, is that we know from a lot of research that the public, meaning non-healthcare professionals, have an unrealistic view of patient outcomes after cardiopulmonary resuscitation, or CPR, with multiple studies showing that lay people believe that their survival rate for CPR exceeds 40 to 50%. There are earlier studies than this one that I cited here, which have shown that some individuals think that the survival rate for CPR can be as much as 75% survival. And I want to contrast that with doctors' views of CPR. And when you look at studies of physicians and what their personal end-of-life preferences are for or against resuscitation, you'll find that a good 90% of people who are surveyed as physicians say that they would not want CPR if they had a terminal or life-limiting illness. So this is in stark contrast to what the public often believes, which is that, CPR is not a big deal. If you get CPR, you'll survive and you go on with life, happily. And I think in some ways you could call this an equity issue, because the folks who are lucky enough to get to med school and study medicine and become doctors, they have a front row view of what CPR is like, and what the success rate is like on the ground. And they recognize that CPR is not the panacea to a lot of ailment that is often depicted in the media. So to give an example, this was a study that looked at some of the top kind of TV shows that have medical themes, like Chicago Med or Grey's Anatomy. And they looked at the number of sort of storylines that involved cardiac arrest. And if you looked at all of the TV shows together, you'll find that there is, you could say, an ageist bias. Most of the people who have cardiac arrest are adults, not older adults. And contrast that with what is in real life, the McNally et al. Study, which finds that cardiac arrest happens, half in adults, half in older adults, but certainly over the majority in older adults. Very small percentage in children, versus on TV, where 15% of cardiac arrest is happening in pediatric populations. So if you look at this colored bar graph on the right, you can see how vastly different the kind of outcomes are for TV cardiac arrest versus real life cardiac arrest. So McNally et al. Again is real life scenarios. And you can see that well over 3/4 of individuals will have immediate or delayed death. And compare that to, Grey's Anatomy, Chicago Med, and you can see where the green bar represents that you survive CPR, and you not only survive, you survive completely neurologically intact. Grey's Anatomy has, 1/3 of their cardiac arrest patients surviving. Chicago Med, almost half of their patients surviving neurologically intact. So you can begin to see why the public who aren't as death savvy as you are may have a skewed perception of what cardiac arrest survival is like. These are some other comparisons looking at traumatic cardiac arrest. And again, you see this huge bias with TV traumatic cardiac arrest being almost more than 3/4 of patients, whereas in real life, it's less than half of those patients. And with traumatic cardiac arrest, there is an even greater incidence, looking at the Zwingman et al., of immediate death. And very few, we're talking about in the single digits, will survive neurologically intact, compared to, again, Chicago Med, where almost half of the individuals who have a storyline of traumatic cardiac arrest will survive and go along with their life as though nothing happened. So let me take this next poll, which is who amongst the audience is certified in basic life support and CPR? So, or you don't have to necessarily be certified right now, but if you've ever taken a basic life support and CPR. Hopefully at least everyone who's watching this on our staff is responding yes. Okay, so we've had about 2/3 of respondents. So, wow, that's really fantastic. The majority of respondents have at some point taken a basic life support or CPR class. And I actually find this is really interesting because I have to say in all of the CPR classes and recertifications I've done, I have never, ever experienced any curriculum or any teacher that mentions the PULST or DNR in the course of the class. So I'm delighted to hear that 5 of you have actually had a teacher or curriculum that mentioned those statements of preference. Okay. So to give a history of CPR, I think it's really important to kind of get background of why and how CPR even got developed. So CPR was developed many decades ago. I mean, if you look at the earliest historical information about CPR, you could trace it back even hundreds of years. But in terms of modern day CPR, we're talking about an intervention that was developed early in the 20th century, and primarily to intervene on an acute event, specifically a heart attack. So when we're talking about a heart attack, we're talking about, if we think about the heart as having blood vessels around it, arteries that bring blood to the heart muscle. We're talking about a little blood clot or a narrowing of an artery such that part of the heart muscle doesn't get adequate blood supply that results in a heart attack. So it's a very specific acute event. Unfortunately, what has happened is that by the 1980s, CPR has become the standard everything practice for all comer patients, whether or not you have cancer, you have kidney failure, you have advanced illness or frailty and aging. So, part of why CPR can be really successful is if you can help someone get through their acute event, a heart attack, and they were otherwise kind of generally healthy-ish, then you're buying them time to get a stent or to get a heart bypass to basically fix that heart. But if you think about all of the chronic illness and debilitating illnesses that we see, for instance, in our hospice, or that we see amongst our family members and neighbors, you can begin to see why trying to apply CPR as a universal standard to people who have illnesses other than an acute heart attack may be faulty. So there have been a lot of studies in medical ethics that have really questioned what is the appropriateness of applying CPR as a standard practice to every patient. And as we all know, the whole purpose of advanced healthcare directives and PULST forms is because in the United States, we have this kind of weird universal standard that CPR and mechanical ventilation is the universal standard for all patients unless they specifically say they don't want them. So it's really the only interventions that are this major that doctors and paramedics and hospital staff can do to someone, can do to a body without actually getting consent. And I'll talk about what these interventions are shortly. So for those of you who have taken CPR classes, you know that we are taught to provide chest compressions, 100 to 120 compressions per minute, and at least 2 inches deep. So for those of you who remember, and those of you who are not familiar with CPR, we're talking about, if you were taking my profile here, someone's got to put their hands on my chest and press my sternum, my chest bone in 2 inches deep in order to cause what we call effective circulation. So the whole purpose of CPR is to physically, manually press on someone's chest, kind of to massage the heart, to physically force the blood to circulate from the heart and to the body. It's also accompanied by rescue breathing, assuming someone wants to do rescue breathing or has the right device so as not to have to do mouth to mouth. And the rescue breathing is intended to help, of course, provide some oxygen, extra oxygen for that body. And then beyond chest compressions and rescue breathing, there is, of course, electric defibrillation if available and indicated. These are the boxes you see in the mall, at the airport, in public transportation stations, et cetera. And this is for very specific types of cardiac arrest, where there is essentially an electrical problem with the heart conduction, because our heart relies on an internal electrical pacemaker to tell it how to beat at a regular interval to sustain life. What we know about patients who receive out of hospital CPR, so that means the person walking down the street or the person at the mall or the person at home who has a cardiac arrest, is that only 1 of 10 of those individuals who has out of hospital CPR will survive. 9 of 10 will eventually die. Even if they don't die right away, they may die, have a delayed death at the hospital or the ICU. There are multiple adverse outcomes that can come from CPR. So it could be aspiration, so if someone vomits and then you're pressing on their chest and they aspirate what they vomited, there can of course be broken ribs and sternum. And this is something that until you've actually pressed on a chest, not the little plastic dummies at the CPR class, but until you've actually performed CPR on a human body and heard the cracking, it is pretty, I will say, traumatic. And brain damage. So even if you get CPR going, and let's say you help that person survive that immediate event, if CPR has been delayed at all by as little as 4 minutes from the time that the cardiac arrest happened, there is likely already brain damage, because it takes just 4 minutes for there to be inadequate or low blood flow and low oxygen level to the brain to cause brain damage. And then psychological trauma. So psychological trauma for the patient, as well as for the people providing the CPR. And then what about mechanical ventilation? So as we know, mechanical ventilation is also sometimes talked about as intubation, meaning the placement of a breathing tube, generally, sometimes through the nose, but mostly through the mouth or through a hole in the neck, down into the airways that is connected to a machine that takes over the work of breathing when a person is unable to breathe on their own. Generally, when someone requires mechanical ventilation, because of the machine's need to forcefully blow air into the lungs, the intensive care unit has to sedate the patient. In some cases, the patient isn't sedated because they have such severe neurologic compromise that they're not fighting the vent, but oftentimes it requires sedation of the patient in order to accept the vent and tolerate and coordinate with the ventilator, the machine. Because if you have someone trying to breathe on their own and they're breathing not in tandem with the breath that's being forced into them by the machine, then you end up with a lot of problems with the ventilation. Patients who are intubated and ventilated, I think this is what a lot of families and non-medical people don't realize, is that it's not like you get a machine and now it's breathing for you, so you're fine. You're sedated, you can't communicate while you're sedated, you're not going to be interacting with your family. And wakefulness, while there are periods where sedation can be lessened to see what someone's neurologic function is like, and in very few cases, some patients can tolerate a vent and be completely awake. Oftentimes, wakefulness is associated with greater signs of discomfort in the studies that look at sedation levels in ICU patients. So, so going through the process of being mechanically ventilated is a really major process and procedure. And for individuals who might already be wondering, I don't really want to ever have a major surgery again, I don't want to undergo anesthesia. Well, mechanical ventilation requires essentially anesthesia and sedation in order to successfully execute this process. So, I describe these two interventions in detail because I think it's important to recognize, what does the media show? What do we hear from our friends? What's our perception of these interventions? And, by all means, I recognize as a physician that there is a very clear and positive role for resuscitation and mechanical ventilation, but in very specific scenarios. Again, the acute heart attack, the person who has a reversible respiratory problem. These types of interventions are much more complex and morally debatable when you're talking about someone whose life and level of illness is already very significant and is already experiencing things such as functional decline, weight loss, and difficulty maintaining one's energy level and wakefulness. So to give kind of a non-medical parallel to, as we think about CPR and mechanical ventilation, when I say that CPR is really effective and it is absolutely the right thing to try, assuming someone doesn't have a DNR, if someone has a cardiac arrest, think about, a car, a well-functioning car that drives really well. It's pretty new. It operates without a lot of problems. And there's just a little hiccup. It has a little problem with the gas line or something. And you need to tweak it and fix it and maybe buy it a little time while it's at the car shop to get it running again. That's fairly straightforward. It is a much bigger and different issue when you're taking a beaten up car that's 50 years old, that's rusted, the tires have no tread on them, the seats are falling apart, the brakes are thin, and you're going to try to fix it with a gas line problem. Well, that's great if you fix the gas line, but if the rest of the car is falling apart and you can barely get the car to go 1 mile, it's unlikely that just fixing the gas line is going to actually help you operate that car. So, not that I want to say that people are cars, but it's a kind of non-medical way to give an image of what CPR is in the context of individuals who have chronic illness and chronic conditions for which CPR was never actually really intended for. I guess I forgot this line, which is 70 to 80% of mechanically ventilated patients will have significant long-term cognitive impairment, as well as we know that mechanical ventilation is associated with increased depression and PTSD. So, all of this is really to kind of double down on what Tamina said, which is it is really important for us to have these conversations, because the only way that we can protect our choices. First is to know what we want and make our choices, but then also express our choices so that the people who are going to be making choices on our behalf are fully prepared in knowing what we want and what we don't want. And so the tools that you can use, as Tamina has outlined, the conversation project, prepare for your care, the documents here in Oregon, are advanced healthcare directives. In some states, health surrogates are identified through a power of attorney. And then, of course, the POLST form. And I won't be going over advanced directives and POLST forms today. That will be for the session in May. We'll go into detail in those, but all of these are the tools, along with simply just having conversations to help you define what you want for yourself and how others can make decisions on your behalf. And with that, I will stop sharing. And we're a little over time, but we can see if there's any questions.
Thanks, Helen. I don't see any questions yet. Just some thank yous, and love the car analogy. That was very helpful. Let's see. If I have a POLST, is it also necessary to have a detailed advanced care directive? Do you want to answer that shortly?
Yes, the answer is yes, because the POLST is very specific to primarily CPR in Section A, but Section B, the POLST does not allow you to legally appoint a health decision maker. Only the advanced directive allows you to legally appoint a health decision maker. So it's best to have both.
Thank you. Okay. In the interest of time, and I don't see any other questions coming in. So thank you to Helen and Tamina, and thanks to everybody for being here today. And like Helen mentioned, we are going to be continuing this conversation on advanced care planning next month for our next Illuminating series, May 17th. And we will be diving pretty deeply into what POLST and advanced directives are. So I hope you'll join us for that. And also, if you, for some reason, the daytime doesn't work for you, you're not able to jump on live, you can register anyway, and you will get the recording and all the resources and everything else shared during the presentation afterwards. So go ahead and sign up, even if it doesn't work for your schedule, but the topic is interesting to you. So, okay, thanks for being here, everybody. We appreciate you, and keep an eye out for the recording and our resources.